Hi, thanks so much for tuning in. We've got an amazing case for you today. We're going to see how blood can flow uphill. And we're going to stress using non-traditional imaging to do a vascular ultrasound assessment. So this is how we do the vascular ultrasound assessment. We use a modified aortic arch view, just taking a regular aortic arch and tilting over until I can see the longest segment possible of the left common carotid. Note the little artifacts here where you're perpendicular to the beam. I placed an M mode cursor so I can have a better idea of how big the pulse is and when the pulses occur. Now this is a standard arch-sidedness view. You can see the sample volume is placed in the innominate artery, and we've corrected for the angle for flow to 60 degrees. Again, modified aortic arch view. You've got your left common carotid here, your left subclavian artery here. Sample volume has been placed and the angle's been corrected. So that way we can see both pulsation and blood flow, check for flow reversal, and get an idea of how big the pulses are. So this is the right common carotid, and up here is the right jugular vein, and we can clearly see that blood is flowing towards the brain here. And over here is the left common carotid. You can see pretty normal blood flow going through the left common carotid. So let's ask ourselves, can we see a pulse? Yes, I can see a single pulse. Is there any flow reversal? No flow reversal here, where there's certainly flow reversal here. So all of this blood has to go to the brain, and we're going to see the echo in a minute to explain how this works. But let's do some detective work. A fluid is non-compressible. It has to come from somewhere, and it has to go somewhere. But let's take a closer look at how this blood is flowing. So here we can see the normal pattern of blood flow. You get a primary systolic wave, a secondary systolic wave, early diastolic flow reversal, and then you get the diastolic flow component. And here's the vein. We can see that it is varying with respiration, but everything's pretty much above the line. Might be a little bit of flow reversal here. Still, this is a big vein with a lot of blood flowing through it. Okay, so the blood has to be going somewhere. Let's go over to the left side and see if we can tell anything unusual. Okay, so we've traced the blood flow. Now we're looking at the left common carotid here and the left jugular vein. It's very clear that we can't answer those questions anymore. Can you see a systolic pulse? No, not really. It's just bouncing around. The jugular vein has these massive pulsations, and that's actually pushing on the left common carotid, so we can't really see a normal pulse anymore. Okay. But the blood flow is normal. I can see a normal systolic blood flow here, but the jugular vein flow doesn't vary with respiration anymore. So here's the arterial flow, and here's the venous flow. Doesn't vary with respiration anymore, and has this turbulent flow pattern. Even though the artery isn't pulsing right, its blood flow is normal, so it's being pushed on by the left jugular vein. Okay, so now we've done our detective work. Blood is flowing from the superior vena cava into the right jugular vein, crossing the cranium, goes into the left jugular vein, flows down to the innominate vein, and this is venous recirculation. This blood is just going in a circle. Okay, so when we use a vascular M mode, we can see that the left common carotid doesn't have a normal pulse. Okay, well, let's look at a normal 12-year-old and see how that blood flow looks. We can see that there's normal systolic pulsation here. Nice normal pulsation. A little bit of flow through the right jugular vein. So when we compare the left side and the right side in this normal patient, we can see the right side, the right common carotid, doesn't really have a normal pulsation. In other words, as you breathe, with inspiration, the systolic pulsation is pretty much lost. So in a normal patient, this is over on the left side, we can see a normal pulse and a little bit of retraction. So this one has a venous influence, a venous component, and this one does not have a venous component. And this is where we would make our measurements to see how big the pulse is. So a normal venous component can be seen in a few normal patients, and in a cerebral shunt you get these violent pulsations. So there's several types of arterial movement that I've been able to identify. You can have distension, that's the normal thing that we can usually see. With a little practice you can see retraction. Occasionally we'll get a venous component. Sometimes the artery is moving when you take deep breaths. And if the heart is beating really hard and the aorta is pulsing, sometimes the left common carotid can have a whipping motion or a jump rope motion, and that would be a cardiac component. So what we're looking at here is a 12-year-old boy who was status post-double outlet right ventricle and pulmonary atresia. He had a Blalock-Taussig shunt that was taken down, and then a Glenn shunt, and then later had a conduit placement. So Glenn shunt is connecting the right pulmonary artery to the superior vena cava. So the cause of the flow reversal then was that the Glenn shunt was in the presence of near 5 meter per second blood flow across an obstructed shunt. Let's have a look at the echo. So here we can see a large right ventricle and quite a bit of unusual septal motion. You can see that the right ventricle is pushing on the left ventricle, so we know that there's a very high pressure. In short axis, we can see this little septal bounce that's being caused by a combination of tricuspid regurgitation and a very high pressure in the right ventricle. Okay, M mode shows the abnormal septal motion. It's a big clue. Always want to check for that. So this shows the obstructed conduit, which I can barely get a signal from. And I'm only getting 74 here. That's probably an underestimation, probably an angle problem. Okay, so here's the tricuspid regurgitation, and it looks like it might be severe. I have to ask the question, how could you have a very high pressure and have severe tricuspid regurgitation? Still, I think I can see the jet circling around, and a very interesting phenomena is called splay, where you get this artifact here. So there's a lot of pressure, a lot of flow. This resolved really almost completely after surgery. So the TR jet suggests a higher gradient, and I seem to trust this signal more than the gradient across the conduit. So now we have the whole picture. We're going from the right ventricular outflow tract through an obstructed conduit into the right pulmonary artery, which has been connected to the superior vena cava, and that shoots blood into the right jugular vein and crosses the cranium, comes down the left jugular vein into the innominate vein and creates this circle. And let's not forget the right subclavian vein and the left subclavian vein. So all this blood is going in a circle, and I just have to wonder how much gradient do you need to have this happen? There's a lot of patients who have this combination of a Glenn shunt and obstructed conduit. So I hope you found this information valuable. If you could click the like button down here, and if you know some sonographers who might be interested in some non-traditional imaging methods, please share this with your friends. Thank you so much for your attention.